Hello, everyone. Thank you for attending today's webinar, COVID-19, Building More Flexibility into Your Hospital Operations in 2021, sponsored by DocuSign. My name is Robert King, and I am a Fierce Healthcare reporter, and I shall be moderating this webinar. Our speakers today are Margaret Pastuszko, Executive Vice President, Chief Operating Officer, and Chief Strategy Officer for Mount Sinai Health Systems, Amy Becker, Chief Medical Officer for UW Health, and Christina Wong, Senior Product Marketing Manager of Regulated Industries for DocuSign. You can read their bios on the left-hand side of your window by selecting the Speakers tab. So a few technical notes before we begin. This webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please make sure that your volume is up. The webinar is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentations with a question and answer session. Please submit your questions using the question and answers tab on the left side of your screen. All right, so let's get started. Margaret, please go ahead.
Thank you so much, and good afternoon, everybody, and thank you for giving me an opportunity to share with you the Mount Sinai healthcare system story during the pandemic and our lessons. I will briefly go over the context and also then our response during COVID first wave, and then really share with you how we applied the lessons learned during the first wave pandemic into what has been our second wave, and then what we are taking out from there forward and how we're planning to do our business differently. And the Mount Sinai Health System is a conglomerate of 8 hospitals located throughout New York City and Long Island. And we see about 4+ million annual patient visits, and we have about 42,000 employees. One of the key factors also that have greatly helped during the pandemic was that we are affiliated with the Icahn School of Medicine at Mount Sinai. So we work very collaboratively and integrate with our medical school partners. It is critical to remember and a little bit rewind in all of our minds what we knew about the pandemic when Mount Sinai was struck with the pandemic, and we were at the front lines of its response. Was a very different time and place than it is today. We were operating in an evidence-free zone, and things moved in record time and changed in record time. We didn't know how to treat COVID and how to respond to COVID except on anecdotes that were coming from Europe. And I think trying to remember that place and time is critical to understanding what our response has been. At the same time, we were greatly helped by New York State issuing a number of regulatory waivers, which really removed barriers, which allowed us for much greater flexibility that is allowed in current and regular times. Everything from relaxation of distance site regulations that allowed us to provide telehealth services within and outside the state, that some of the EMTALA waiver and consents for transferring patients were waived, so we had much more flexibility. We got relaxation of documentation, physician privileging, as well as relaxation for requirement of physical space, and I'll take you through some of that in detail. To put it in, again, context, the first wave pandemic for Mount Sinai lasted about 2 months. We got our first patients on March 7th. We reached our peak on April 6th, and we discharged last patients from but I'll go into more detail, Samaritan's Purse Field Hospital, May 5th. And then we also continued further decline in the numbers of COVID patients. And what did we deal with? At the peak, Mount Sinai Health System had about over 2,000 patients. The duration from the peak to a 50% drop in COVID census lasted 3 weeks and 2 days. And believe me, we were counting. During that period of time, we implemented 121% incremental capacity in ICU beds and 56% incremental capacity in medical beds, which meant we added over 1,000 medical beds. And we did this as a result of a full programmatic shutdown, except for emergency procedures. Many factors contributed to Mount Sinai's ability to sustain its operation in wave one, and I'll go through each one of them very briefly. Even though I provide quite a few information on the slides, I'll touch the high points. Structure and organization through a unified command center was actually put in place before COVID, but really materialized and made a huge impact during the COVID pandemic. We triggered the command center in mid-February, and if you recall, the first patient didn't arrive until March, the first week of March, to Mount Sinai. It was an emergency management unified command group, which we called UCG for short, and we had 3 individuals who were making interchangeable decisions: the chief clinical officer, chief operation officer, and chief medical officer, and included all the key components of our organization and partnered side by side with infection prevention at every step of the way. The command center was empowered, frankly, to make decisions and to make those decisions in real time. And we had to be very comfortable with the fact that we also had to change and adjust repeatedly and had to make decisions with data which was available at the time and the best data that we had, and constantly changing guidelines. We centralized and dispersed best practices and learnings. We mobilized the resources. We very much balanced patients across the system and focused very much on communication. Although I can't say we were always perfect, we tried to keep moving despite the greatest adversity. We have developed in the process a great deal of clinical protocols for treatment of COVID. And again, as you can imagine, these were constantly changing. We gave guidelines in terms of where the patients presented themselves, what type of patients there were, whether they were adults, whether they were pregnant. We created pathways for airway management and oxygen needs, as well as special resource needs. For example, we created proning teams, etc. We also really focused at the very beginning, even as early as the first week of March, on creating and understanding how to deliver care in a time of constrained resources. You hear quite a bit about this even on TV these days around lack of resources, for example, in India. Well, at the beginning of the pandemic, we were faced with the possibility of not being able to provide exactly everything to every patient. So we really thought through very methodically, what are the conventional operations, what are the contingency operations, and then what would our crisis operation look like, and what would be the triggers for initiating each one of those strategies, like substituting, adapting, reusing, and reallocating. Thankfully, some of the most severe options we never had to pull out of our toolbox. So that's we've been very grateful. As I mentioned before, the regulatory environment allowed us for using non-traditional care spaces, which we did. We created space within existing footprint by adding additional beds. We pretty much doubled up every ICU bed, every ICU room that was feasible. We also created beds within our lobbies, atriums, and cafeterias. You see an image. This is actually an aerial image of our biggest hospital, Mount Sinai Hospital, and we built enclosed locations for over 60 beds into our lobby of Mount Sinai Hospital. We also put up tents at each one of our hospitals to expand care spaces. And in some instances, we actually put up more than one tent outside the hospital. And we were really had a great opportunity to partner with Samaritan's Purse, which is a volunteer organization that goes into the hardest hit areas in the world to provide medical care. And they actually set up and opened a field hospital, believe it or not, in Central Park. I know that it's hard to imagine walking through Central Park these days, but back then We had an entire field hospital that held over 66 beds, which took care of over 200 COVID patients at the most difficult moment in time that we were going through. And you see some of the images of the field hospital. We've spent a lot of time and effort balancing patients across the system. Smaller hospitals were definitely not in a position in wave one to accommodate a sudden influx of patients. This is one of key lessons that we learned, and you'll see later how. We've been making transfers of patients our top priority, and you see here over the time frame where we really got hit. And at times we were transferring upward, as high as 80 patients per day across our systems, when usually the baseline is about 20 to 30. Out of interest, we did transfer some patients to Javits, which was the state set-up center. They were very low acuity. It was mostly convalescent patients. And we did transfer a few patients, 19 in total, to USS Comfort, which was the federal ship that docked in New York to help with the wave one. They did not accept COVID patients, so that was the limiting factor. A critical piece without which we would have failed was we needed to support and supplement our frontline staff with additional resources. Overall, we brought close to 1,000 external staff, mostly in March and April, and predominantly RNs, nurses in ICU, ED. We also redeployed a great number of staff. We brought in about 200 of our ambulatory physicians to help in the front line of COVID. And one of the great advantages is we also had medical students who were in the medical school who were volunteering and helped us. This was all made more critical because our staff themselves were getting sick. They were not immune to COVID, and at the peak of the pandemic, we had about 1,200 of our staff members out with COVID themselves. At one point, about a third of one of our smaller hospitals' staff was affected with COVID. And that was, critical to our response. We provided hotels to have staff not have to go back home for the fear of infecting their families. And we spent quite a bit of time on some of these external resources. All these shortages led us to developing a number of provider coverage models that were unique and were team-based. And I'll very briefly take you through 3 examples of that. We created an intensivist model that created a tiered staffing model utilizing non-critical care physicians, leading smaller teams overseen by an intensivist. The teams of some of the non-critical care physicians included anesthesiologists, pulmonologists, surgeons. We have also created a medical provider model where a super hospitalist provided oversight to multiple teams of non-hospital attendings with additional residents for oversight of patients. So we try to leverage the expertise of the highest in-demand specialties. That also existed in our nursing staffing model. So an ICU team leader member model had staffing tiers where we had a team leader with an ICU-trained nurses, which had an entire team under her where when we created role delegation, who does what, body system based on the comfort level for deployed staff, re-education, transitioning of assignments as people were becoming exhausted, etc. So it was a very flexible model. And these are just 3 examples of multiple models that we put in place. While doing all of this, we tried to do everything possible to support our frontline staff. So we created a relief program, which thankfully was greatly funded by our Board of Trustees' commitment, as well as just an unbelievable support of our communities. And the programs included Frontline Relief and Wellbeing Center, Snack and Wellbeing Stations, and Frontline Meal Program and Serenity Room. And I just included a couple of pictures. Believe it or not, they provided a moment of peace and tranquility to our staff who've been, unable to go home and in the front lines of COVID. Without clear materials management, it would have all have failed. So supply chain was a critical component of our response in order to make sure that every hospital got what they needed when they needed it. We consolidated all inventory. We created a multi-departmental team to focus on international sourcing. At the beginning of the pandemic, I personally would get at least 30 to 40 emails with, opportunities to purchase supplies and even donations. But not everything is equal. So we had to create a complex team to make sure it meets our standards and we can get it in. We acquired, even in February, anticipating what's likely to happen, and we stocked 2 warehouses with products. And we made over 4,000 deliveries to all of our 8 facilities and over 75 sites across the system. All of this was helped through a constantly evolving application of science and predictability to supply chain. So we created a daily burn rate and days inventory on hand that were being driven by real-time indicators, and created a COVID-19 PPE model. So we knew who was likely to run out of what within what time period, whether it was 24 hours, 48 hours, etc. So we can get and stay on top of the equipment to the facilities that needed it. And we deployed that equipment and supplies in real time. So we centralized our equipment deployment. We moved about 2,700 pieces of equipment across the campuses, everything from feeding pumps to respirators. We just leased a whole fleet of vans that we ended up using ourselves across the system. And as you know, ventilator capacity was always constrained, especially at the beginning. So we spend, with the help of the medical school, a lot of time creating non-traditional ventilators. And I have to say, we were glad we didn't have to use some of them, but, within 2 weeks, we had simulated ventilators to facilitate splitting ventilators to support more than one patient. I was quite amazed. We actually created a protocol including a 3D printed valve. Until that moment in time, I never realized what 3D printers could do. And the final component of our response was telehealth. And in that, we wanted to have eyes into every unit, every ED, every tent, and every surge space. And we created telehealth, which we hugely deployed. We ramped up from 8 to 242 teledevices in Wave 1 and added over 500 patient visitation devices. And so that was a huge response. At the same time, we also quadrupled in our ambulatory telehealth volume. So some of our critical challenges in Wave 1 was we didn't know what the clinical profile of the disease was going to be. We were learning, discovering, and adjusting along with the disease being with us. We had a virtual command center, so we couldn't rely on traditional communication tools. There was huge stress on very specialized services. We had a very decentralized system that we had to change quickly to a centralized model. And we had a huge uncertainty in external supply, and every delivery estimate was being delayed. We actually, by the way, did charter a few planes and shipped our own equipment from China directly. And we had a very small virtual care platform at the time. In wave 2 is where we applied a lot of the lessons learned. And this was just recently. We just started on our trend downwards. We were at the peak at over 550 patients, and we still had quite a few of our employees on isolation. We added 26% in incremental capacity in ICU and 17 in medical. We did not close our programs to accommodate these patients, but we did reduce them at some of the sites, but we never halted them. So COVID-2 allowed us for testing some of the lessons learned from wave 1. We acted as a system. We set up and hardwired communication. We prepared and set triggers for response before we had to respond, and we had a real-time activation command center. We preserved and maintained urgent work, so we didn't shut down. We really conserved and built bench strength across the system in all disciplines. We created cross-training. We made sure that our frontline staff did not lose some of the learnings they've gained from wave 1. And one of the key factors was that we went into a partnership with a number of independent hospitals. This was facilitated through the state, but this was to protect some of the independent hospitals from imploding, like some unfortunately did in wave 1, not within Mount Sinai Health System. But if you couldn't rely on a seamless transition and help, it was very difficult. So we had a very much coordinated approach. So finally, what are the long-term impacts of how we do business? In certain areas, we will never go back to what we did pre-COVID. The central transparency into the system is now hardwired. We've integrated throughput, labor, supply chain, and pharmacy. We also integrated our bed management systems. In our facilities, we are building much more integrated bed flexibility for isolation, for intensive care, and for telemetry, even if we don't have to use it on a daily basis. Labor impacts and lessons that we're never going to hopefully repeat. We are moving to real-time staffing visibility, cross-training of our nursing staff, systemization of key roles like dialysis and wound care, cross-credentialing of providers across every single hospital. We're making sure that occurs, and team models for care delivery and actually simulation of that care if needed. And obviously, we will never go back to lower utilization of some of the technologies that we have put in place, whether it's telehealth or remote monitoring across all of our sites, so that we can get the best protocols across all 8 hospitals and our ambulatory sites in real time. So with that, I will turn over to Amy for her experience. Thank you.
Great. Thank you, Margaret. Boy, as we think back to early March and the early time of the pandemic, what was happening in New York was sobering, and I really appreciated that opportunity to hear about your experience with that. I think it was, in addition to being sobering, I think also very motivating for those of us in healthcare. And I think you'll notice some very familiar and similar themes as I go through my presentation. So I'm going to walk us through what worked and what didn't go well for UW Health's COVID-19 response. I'll share what we're excited about for the future of healthcare based on what we've learned from our COVID response, and I'll also share what we're worried about. And lastly, I'll share some tools and strategies for working differently in the future. So a little bit about UW Health. We're the integrated health system of the University of Wisconsin-Madison. We care for more than 650,000 patients each year with around 1,800 physicians and 21,000 employees across 7 hospitals and 77 clinic locations throughout Wisconsin and Northern Illinois. We work with our partners at the UW School of Medicine and Public Health, and with this partnership, we've been on the cutting edge of patient care, research, education, and community service for decades. And we've also been the #1 hospital in Wisconsin for 9 years in a row, according to the U.S. News and World Report. So what worked and what didn't? I'm going to walk us through some reflections on this. And, overall, I will say that there was some component of, quote unquote, didn't work well in nearly all aspects of what worked well, right? This was a work in progress, and continuous improvement was our mantra. I think the key was definitely learning quickly from this and not letting the same didn't work well impact us repeatedly. Just a little more background. UW Health treated the first case of COVID-19 in Wisconsin on January 30th of last year. And, our worst surge of cases impacting hospital operations really didn't come until the fall of 2020 and peaked in mid-November with about 100 COVID positive inpatients just specific to our health system. So the what went well of UW Health's early COVID-19 response can be summarized by the following. Our incident command system, much like Margaret shared her experience, I think employing early safety measures, our progressive planning, and I'll talk more about that, and caring for our staff. So as noted, I'll walk through each of these in a little more detail and share what didn't work at times. As these are examples of lessons learned, but certainly not everything went well all the time. So, I mentioned the early activation of UW Health Hospital Incident Command System, and really this was key, as we heard from Margaret as well. This was an enhanced version of our traditional HIC structure that included operational leaders and specific work groups, along with project management and data and analytics support, so a robust operation. And this was raised to level 1 activation March 12th of last year. And this photo that I'm sharing with you is from March 13th of last year, and I got to say I cringe when I see this, right? It's just such a striking visual reminder of what we didn't know. And we learned so much quickly, but when I see no mask, no physical distancing, right, this really is a great visual of where we were starting. But however, because, of this highly functional enhanced HIC structure, we really quickly got to where we needed to be. And then this structure stayed in place for us at UW Health until March 1st of this year. So, and then at that time, all operations were transitioned to routine operations. We stood up a COVID management team of senior leaders, which helps address COVID issues that require more attention or support than can be delivered through standard operations. And so at the time of March 1st, the largest need for this COVID management team was ongoing immunization planning and work. And overall, that has gone well. Beyond the traditional HIC structure, this enhanced version included a structure of daily briefings and huddles. Huddles are short meetings for groups to touch base, get updates, share information on what's working and what isn't. And that was really, really important for us. And the rotating HICS team also used go-and-sees, which are visits to observe the work where it is occurring, to better understand the work to address barriers and inform decision-making. So if we were having challenges with our visitor screening at the front entrance, the team would go and see on the front lines and speak with folks there to help, again, address barriers and better inform decision-making. And this worked well for us. I will also say that new work groups were established to meet COVID-19 demands, and these were multidisciplinary teams that tackled everything from childcare needs to COVID-19 patient care to our visitor policy, and these were supported by project management, data analytics when the task at hand was large. And then these groups were sunsetted when the work could transition to routine operations, and then new work groups were formed when needed. And I think a good example of this, again, is immunizations later in our COVID response timeline. For UW Health, all of this added up to our incident command on steroids, really allowing us to be nimble. The HICS provided the transparent and clear structure and process for organizational decision-making, the who, the how, and the what, to accomplish so much very quickly. And I think we heard that from Margaret as well. It really fostered that quick, centralized decision-making based on the input and recommendation from specific work groups. So this group wasn't working in a vacuum or a silo, and that those huddles and go-and-sees and input from the work groups was really, really important. The communication planning associated with the decision-making from HICS was also built into the process, and this worked well. What didn't work well didn't work well reflections, certainly there were times, especially early on, when relevant stakeholders were inadvertently left out of the process. For example, early on, we didn't think to include inpatient units that didn't provide COVID care in our work group for the visitor policy, for example. Or, in our very, very early planning for our, critical care expanding needs, we didn't pull pharmacy in at that first meeting. I think just in the haste of things, right, we missed some key stakeholders. So lesson learned there, ensuring that appropriate interdisciplinary stakeholders are involved at all times. Also, despite being a large, complex academic health system that can often be slow moving, I've heard somebody liken this to the snail's pace of turning an aircraft carrier. We were deliberate about not getting stuck with analysis paralysis, and we heard that from Margaret as well. We made decisions based on the best information we had. We know it wasn't great information, and when this information changed, we adjusted, and this did work well. Early safety measures were rolled out by HICS, again, based on the best available information at the time. And, we all remember PPE was in severe shortage, testing capabilities were minimal, and we were really worried about keeping patients, providers, and staff safe. We were also preparing for mass provider and staff shortages due to illnesses as well. And because of this, we restricted visitors and stood up telemedicine infrastructure in a matter of weeks, setting up inpatient providers with access to first in anticipating worker shortages and also to conserve PPE. And we also moved to support remote work as much as possible. And then we also transitioned then to our ambulatory providers with the means for telemedicine. Also, in the interest of keeping all safe, we postponed non-essential surgeries and procedures, which allowed time for staff training, for redeployment, fit testing, PPE conservation, and more of our progressive planning, which I'll talk about in a moment. And really, all of these early safety measures were implemented quickly because of the nimbleness fostered by that enhanced incident command structure. Our communications team, in partnership with our incident command and others, supported constant communication to our employees, our patients, and the community. And this, particularly the external communications piece, was a key ingredient of what worked well to foster flexibility for the health system. We needed to get accurate and changing information out quickly and have a venue for correcting misinformation. So to support this, we used daily public and media messages. We established a new website and leveraged UW Health experts to help in this responsibility to the public. And there were days where we had as many as 20 interviews with media outlets. Also, through our operational channels, we stayed and continued to stay connected with other health systems in the community. And with the help of our external liaisons and communications team, we had a unifying message to the public. Whenever possible, we tried to coordinate announcements with other health systems to have that consistent message for the public, like when elective surgeries and procedures were dialed back in our community. This wasn't always practical, but the effort was there from all. And we really hope that this has built sustained trust from the community in healthcare and in public health efforts, especially as we focus on the necessary immunizations to move us out of the pandemic. I think, next up, an example of what worked well that hopefully can be applied to future flexibility for hospital operations is what UW Health called progressive planning. And you can see what it was and what it included. And so, I described this as a scalable plan that addresses the how to care for varying levels of COVID-19 patients while maintaining access for essential non-COVID patient care, including in the outpatient and inpatient environments and across the acuity care spectrum. We all know that non-COVID patient care needs didn't stop with the pandemic, and continuing to care for those with heart attacks, strokes, trauma, cancer, and other complex needs really needed to be part of the planning. And so our aim was to ensure we addressed all requisite components of patient care and knew how to dial back and dial up that non-essential patient care. Along with the data analytics for, our PPE and supplies, the planning also included the specific, how to care for COVID-19 protocols and guidelines. And we had the plans to create the appropriate, negative pressure environments, our facilities updates in specific locations, along with the expanding staffing plans for providers and nursing, redeployments from other areas, and developing crisis standards of care. And so the plan also included expanding EICU services, offloading low acuity patients to, alternate locations, as Margaret described as well. And we really developed a plan to use all of the space and people resources we had access to. And fortunately, we didn't have to flex all the way out into this crisis surge plan, but we have lingering flexibility in our operations from this work. Just like Margaret described, I think overall the scalable plan has allowed the flexibility to continue to deal with the COVID-19 unknowns with respect to local cases and hospitalizations, and has allowed us to continue to do this all while providing that really essential patient care to all. Another critical piece was taking care of our people. We all know how important this one is, and for UW Health, like others, we heard from Margaret about this too. This is high priority. While this list here isn't exhaustive, but shows some examples of how we supported all of our employees, including those on the front lines. And this is where our communications team was a tremendous help. They helped share the stories of those on the front lines and our patients, both internally and externally, and help spread the message of gratitude. I think we all understand that this continues to be really important work for the future. And now, as we think about the future, I'll share briefly what UW Health is excited about and what we're worried about. So I'll do the fun stuff first, what we're excited about. So we're excited about continuing to work differently by leveraging technology for better patient care and improved staff and provider satisfaction. So our employees love the remote work option when appropriate, and this has been a COVID silver lining. It has allowed us to optimize use of space as well, which it feels like we never have enough of, and brings some flexibility and satisfaction for our employees. Of course, this hasn't always been easy, and there's a balance to strike in this realm, but overall, this is going well, and we look forward to optimizing remote work in the future. So that's a great segue to telemedicine. And, for some providers, this remote work option for some of their patient care has been life-changing. And for some patients, alternate visit types are a huge boost for the patient experience. So like remote work, striking the right balance in telemedicine can be challenging, but we're excited to continue to work through the challenges. You can see that when the pandemic hit, we quickly transitioned to phone visits and then quickly increased our video visit capacity. And then with the slow decrease and then leveling off of our phone visits. So we're really excited to continue to enhance both our patient experience, but that of our providers and staff as well through our telemedicine options. So what we're worried about, right? These are things I think we're all worried about. The pandemic is not over. We're still in our race to herd immunity and to stay ahead of the pandemic variables like variants. And so we're not across the finish line, and we'll need to continue to be flexible to accommodate varying amounts of COVID patient care while maintaining our other essential patient care services. We're also worried about the consequences of deferred care. We've all heard the anecdotes about concerning cancer diagnoses after deferring routine cancer screening care and what this means for our patients. We also worry about the status of routine immunizations in children and what this means for the future. So in short, we're worried about the health of our patients from deferred care during the pandemic. We also are worried about our people. It's been a stress year, and as the acute stress of facing a pandemic has changed to the smoldering chronic stress of an ongoing pandemic, we worry about the health and well-being of not just our patients, but of our staff and our providers. We need to be so careful about managing the workload for our teams as folks are worn out. And this is tough, right? We've all deferred so much important work over the past year because of the pandemic, but we need to be respectful of our teams, and balancing this and managing this as we move forward will be critical. And lastly, we're worried about continued financial headwinds. We're lucky in healthcare that our daily why is lofty, right? Nothing, is that true north of patient care is a great reason to come to work every day. And in order to continue to do right by patients, despite being disrupted by COVID-19, we'll need to continue to weather the financial challenges we face. And there's a lot of uncertainty here. So for UW Health, what will we carry forward from our COVID-19 response lessons learned for working differently? So I'll share some thoughts about this. For most part, these are things I've mentioned already, but I just want to highlight those lessons learned quickly. From what went well. So through clear and transparent structure and process through our incident command, the who, the what, and the how, we will, we were able to foster nimble decision making, and we look forward to carrying that type of nimble decision making forward. This also includes stopping work that is no longer high priority, right? Managing that workload for our teams. We'll also need to avoid analysis paralysis and leverage cross-functional or interdisciplinary teams, including operations on the front line. We will use huddles to cascade information up and down along with other standard communication structures. We'll continue to use our go and sees to better understand the work as it is occurring to inform decision-making and remove barriers. We'll continue to work to communicate effectively, both internally and externally. This really provides the transparency to build trust, both, for our employees, but with the community. And we'll continue to help get the work done through the right resources. And our leaders will continue to be visible, engaging with employees to learn from them, support them, and give thanks, as this has proven invaluable and will continue to be important. And then lastly, a little bit of fun stuff. As we heard from Mark, necessity bred innovation during the pandemic, and we look to continue to leverage our innovation and partnership with the University of Wisconsin School of Medicine and Public Health to improve our future care and patient operations. So here we see just a few examples of this. When we couldn't get hand sanitizer we partnered with the university and pharmacy to make it. And when masks and face shields were a barrier to patient care, our speech therapists partnered with the university engineers to come up with something better. And, of course, partnering to support research opportunities to safely add to our fund of knowledge to battle COVID-19 are just a few examples. And again, we look forward to continuing to foster this innovation to improve patient care. So again, I really want to thank everybody for this opportunity to share UW Health reflections from our COVID-19 response. And, hopefully this will help us work differently for the future. And so with that, I'll hand off to Christina Wong, who is our sponsor today, to hear more about DocuSign.
Thank you so much. Hi, everyone. I'm Christina, and I'm here to just give really brief remarks around how DocuSign has helped our partners and providers really try to address some of these broader operational issues that we've discussed today around having technology be a tool and a resource for you to be able to make these plans become reality. And technology is here for you to make your life easier, to be able to focus more on your patients. And technologies like DocuSign are really focused in around improving operations because we believe the world is run on agreement. So before I go deeper into that, just first a little bit about DocuSign in case you haven't heard about us. But we are a company that had initially focused on e-signatures, but have really broadened out our suite to be able to digitize the full agreement process, which means that for any documentation, we think that all the paperwork, whether it's CAAs, HR paperwork, informed consent, you are able to digitally prepare those documents, get them digitally signed in a HIPAA-compliant way, collect those documents and make sure that they're managed appropriately in whatever system that you need, whether it's in DocuSign, your EHR, or your HR ERP type of database. So our solution is actually used throughout healthcare. We are more than in 100 health systems, over 1,400 healthcare providers, and very prevalent in the healthcare ecosystem. So some may start with some like HR or contracting use cases and move us to registration, patient intake processes. They typically may start small and then continue to grow their use of DocuSign as more and more departments start to realize the value. And for us, our customers here have really used DocuSign to focus in on three main constituents around making the lives of their patients, their employees, and their clinicians' lives all easier by digitizing a lot of that paperwork that needs to happen as part of your operations process. So when we think about operations, this is one particular use case that we saw a lot of our customers or providers come to us with during the COVID-19 crisis. This is one example of many, like I mentioned earlier, that we could help digitize, because you might not realize how much paperwork and processes and redos are involved with just one simple process such as patient admissions and consent. So for us, we saw like our customer, Houston Methodist, come to us and say, our patients are scared to come into the hospital and they don't want to have to wait in the room longer than they need to. Help us with our registration process and be able to get them fast-tracked. And so from us working with Houston Methodist, we were able to get 50 to 75% of their patients fast-tracked, completely registered, signed, and paid prior to their arrival in less than 3 months. And they sent over 10,500 packets in just 1 month. And this only took a month or so to get live. So as you can see, by just digitizing this process, you no longer have all of these sort of squiggly lines going everywhere, but instead creating this touchless digital experience where each patient really was able to reduce the intake process time, reduce the number of employees, focus on the registration time, and that these consents that need to get signed are auditable and not lost. So again, this is just one example of how you can think about a digital solution like DocuSign in improving your operations. And we've seen the various ways that our customers or new customers have come to us to help them. As you can see here, this is sort of a range of the way that the products were able to adapt to whatever the COVID-19 pandemic had to offer, but also see us as an investment to meet the future needs of healthcare that we have to be able to transform this industry right now based off of what we learned from COVID-19, as each of the presenters talked about, of what they're moving forward with in improving their operations and what they learned from COVID-19. So here, just to briefly highlight what we saw, as the speakers mentioned, a huge use in telehealth. Most of the people needed a way to get those HIPAA consents or those required documents just to be able to get the patient in the door through telehealth. And what's really important here as a theme of all of this is making your patients' lives frictionless so that you don't lose those patients, that you're able to get them back in to see you in person as well, besides telehealth. So we saw that a lot, particularly around when people needed to come back, was around clinical research. So clinical research, the hospitals needed to see infected patients or potentially infected patients, and so they used DocuSign's special product that adheres to the FDA requirements for 21 CFR Part 11. And we were used a lot for mobility needs. When you look at COVID-19 testing sites, people would drive in with their cars, be able to use their cell phone, scan a QR code, bring up the patient consents and other paperwork, sign it digitally just on their mobile phone, and be able to get a COVID-19 test. So everything was contactless. But it also speaks to our accessibility and mobile ease of use for the mobile phone and texting abilities available when you think about operations. It doesn't always have to be something that's focused around a lot of cumbersome processes. When you're also looking at operations, you might also need to think about how do you identify people's identity. And so we saw with Engaged MD, they used our Identify product to make sure that those who were interacting with fertility clinics were who they actually were. So we see that a lot actually with credentialing. As the speakers talked a lot about staffing and the big changes in staffing, we see that what we see with fertility clinics with the use of our e-signature plus identity verification could be very valuable for potential needs in HR and staffing. And then lastly, when you look at the upper two around what we did for behavioral health and the providers, a small provider called Mimit Health was about being able to scale. So with behavioral health, there was a lot of training that needed to be done for this really small customer of ours, Heart-Centered Counseling, where they were able to train their staff very quickly within 2 weeks using a lot of the self-service tools that we have. And then Mimit Health was really able to increase revenue and reduce costs by being able to see more patients, and physicians are able to focus more on the patient instead of having to spend a lot of that time on administrative work. But it also enabled them to grow globally in that they were able to reach geographically farther than they were able to before. So when you're thinking about operations and this ability to not only change management and get your staff up to speed, but how do you continue to scale and grow and gain efficiencies? DocuSign has been one of those technologies that was able to initially start out, small, but scale and grow as all of these sort of customers have shown when changes happen to their needs. So just to wrap up, I just wanted to iterate that DocuSign is just one example of a technology that you can use. There's plenty of other technologies, but we have seen when you think about your current tech stack about how do you optimize what you have, and then where do you think that you want to bring another solution in, and it could really help you continue to meet these needs that you see and really be able to put in place a lot of these great learnings that you had through this very crazy and difficult year that we came out of 2020. So I will now turn it back over to Robert.
Great. Thanks so much for that, Christina, and thanks. So now we're going to be moving on to the Q&A session. There is still time to submit your questions using the Q&A tab that is located on the left of your screen. So we have a lot of great questions, and we'll try to get to as many as possible. So the first question that I have is, one of these interesting questions is, with 2,680 pieces of equipment that we're moving, I think, Margaret, this is for you, how did you keep track of where the equipment was when you were having, a lot of these issues?
So thank you. That's a great question. Actually, at the beginning of the pandemic, we just deployed physical teams from our re-engineering performance improvement teams across all of the hospitals to have good surveillance. And I think Amy also kind of alluded to it, that nothing replaces that. And then we frankly just kept track of everything. It was at that point slightly manual in the beginning, and then we developed a system that we could actually do the inventory tracking in real time. but in the beginning, I won't lie to you, it was a darn spreadsheet and just amazing teamwork in terms of making sure that the beds that we redirected got to where they needed. And let's just say after wave one, it was quite a fun opportunity to try to clean it all back up and get everything where it originally belonged.
Great, thanks for that. And my next question is for Amy. So, Amy, have the increases that you've seen in telemedicine patient care at UW Health been sustained?
Yeah, thank you, Robert. You know, the good news, the short answer is yes. So as you think back to that slide where, you know, quickly we transitioned to phone visits and then increasing numbers of video visits, we've really seen a sustainment in that video visit. And I think, you know, the upside there is it really can be a good experience for both patients as well as for our providers. And, you know, with this, we fast-tracked our strategic planning in telemedicine and have developed a robust plan to how to optimize this for patients and providers in the future. And, of course, there's lots of challenges with this, right? There's state licensure issues, patients afar, billing, and so on. But we're excited to work through these challenges really as a COVID silver lining. So I think that was a long-winded answer to the question. But, yes, we've definitely seen a sustainment in that activity and looking to increase that in the future.
Great, thanks. And Margaret, I have another question for you. Did the business volume recover after wave one to pre-COVID-19 levels, or is that still kind of lingering below?
Thanks. So after wave one, by the end of last year, we were back to about 95% of pre-COVID levels, just in general. It wasn't evenly spread across all of our business lines. So I think one of the most lagging areas have been orthopedics and musculoskeletal. And their recovery was much slower, and we are still not there, especially since wave two is hit us then in the beginning of this year. But overall, we got to about 95%. Now, I will say that, you know, some of that was probably deferred, right? So I think in the next couple of months, we'll see what happens in the longer term return, but because I think some of that, what we saw at the end of last year were all the procedures and all the healthcare outreach that occurred because we got past wave one. So again, as Amy said, long-winded answer, yes, it did on paper up to 96% of pre-COVID volume, but the answer is not that simple. Thanks, Robert.
Got it. Thank you. And Amy, I have another question for you. Yeah, and this is also kind of what's happening, you know, as we move to a post-pandemic, you know, period as well. So, were there any issues with the transition out of centralized decision making when the incident command was kind of stood down in March?
Yeah, thanks, Robert. I think that's a good question, right? We had our level one activation of our, you know, incident command on steroids for nearly a year, right? And so, you know, I think people were ready to get back to routine operations and have that decision making at the more local level, if you will. So, you know, I think folks were excited about that. Of course, timing is everything, and so we're careful about that. So I think overall that transition went well. There weren't really any big issues that I can think of. You know, certainly that COVID management team, so that group of senior leaders that continues to meet as a venue to bring COVID-specific issues continues to be important. You know, I mentioned around our immunization planning. You know, fortunately, the pipeline supply aspect of our immunization challenges we're no longer faced with. And so now that team is really working on, along with partnering externally, right, to ensure we're ready to support what we hope is a soon expanding pool of folks eligible, those 12 to 15-year-olds. And so, that's the focus of the work. I think there's, lingering issues that get raised there, particularly around the infection control realm. And as, we've both seen, obviously, our employees immunized, but then also our patients, and that sort of changes, our approach to different things. But overall, I would say no big issues with that.
Great, thanks so much. And this will be our last question for Margaret. What were any barriers within the organization to kind of putting together a timely response?
I think at the beginning, frankly, and only at the beginning, there were just the traditional roles that existed within an organization that everybody had to think through and say, well, this doesn't work for this situation. The titles that's in the very, very beginning got in the way, and disruptions within the existing organizations, which I have to say those were the barriers, but we overcame them incredibly well, and I think that's one of the things I'm so unbelievably proud of our team in kind of eliminating what are the traditional roles and thinking about what the outcome needed to be. And you even saw that in some of our, staffing tiered models. Who would have thought that we would have surgeons on proning teams and doing nursing functions? But at the beginning that was kind of unheard of, but then it became so obvious. And everybody just jumped in and figured out what part of the team they can help with and make all of those traditional roles go away. And I think that was a huge secret to the success, although a barrier at the beginning.
Great. Thank you so much. That was our final question. We had a lot of great questions today, and sorry that we couldn't get to them all. I wanted to thank everyone for attending this Fierce Healthcare webinar and submitting so many great questions. I also like to thank our speakers for participating and DocuSign for sponsoring today's webinar. The webinar has been recorded. You will be able to access that recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.